Yeah.
Hi, Mama. Hey, wait a minute. No. Are you going to deliver the pizza?
How do I know this?
I hope so. I'm due today. What?
Come on out.
I know. My
Don't
aunt
know
lives
where
next
I'm
door. I'm going to be induced on Thursday.
But you don't want to.
I don't know. My aunt had a dream that I had the baby on September today.
That's a good trying to play in that, child. Put on the gun, Johnny. I should wait with it.
I don't even have to turn the chair. Oh, it's over one. No, I'm ready to get. I think it's chair.
Would have been, but you don't. All right, let me go ahead and start for all the people who aren't here. I'm going to, yeah. I haven't started it yet. I don't think.
That's what I was wondering. I'm like, I'm really not going to do it.
A lot of this, again, should be review from Lori's farm class, but an alternate form rather than an MDI, we can use DPI. Again, it's in a powder form. It's less expensive. There's no chlorofluorocarbons. You don't need as fine of a hand-breath coordination. And there's a bunch of different types. Some of them are single dose. Some of them are multi-dose. In fact, most of them that you'll encounter now are multi-dose. And there's some examples of them there. Biggest thing that you need to remember is that they're going to require a higher flow rate. In doing so, you may have an increase in pharyngeal impaction as opposed to actually getting down into the lungs. They also is a problem of them being of patients exhaling into them, and that's going to it's going to cause the medication to be dispersed. And it's affected by high humidity, and it obviously cannot be used on patients that are being mechanically ventilated. So again, we're going to assemble the apparatus, and again, there's so many different ones that we're not going to expect you to know each and every one of them. You will need to know, though, that we should exhale to residual volume, so it's maximal exhalation, and then sealing the lips around the mouthpiece and inhaling rapidly. And then once you get to total lung capacity, having a big breath hold, and you can repeat the process if you didn't exhaust the capsule that was that had the medication, and so you can take multiple breaths from it. At least 10 seconds. Similar to an MDI. So one of the PEs we will have is to use a DPI or an MDI, and there's some apparatuses that will pass out when there's more of you here to get to you. What about if I want to give a large dose of bronchodilator? Well, there's a couple different methods that we could use. Certainly this would be done by a protocol, but there's 4 primary ones that I want to talk about to be able to utilize this. There's an algorithm in Egan, and you can see there's the 4 of them there. First one is basically where we're using an undiluted medication. So we're using albuterol by itself. The key part is that if you're going to do that, you need to have a specialized nebulizer. You can't just use your old-fashioned one. And different types that are there. First of all is what's called the Aero Eclipse. It's an breath-activated nebulizer, or breath-actuated, I should say. This is what the internal thing looks like, but the key part I want you to notice is that it's only nebulizing during the inspiratory phase. So it senses when the patient's taking an inspiratory effort, nebulizes during that time, and during exhalation there is no nebulization that goes on. And very, very effective. Take a look at, compared to our normal lung deposition of 10 or 15%, here I'm getting almost 75% and less deposition that's occurring inside the throat. Breath-enhanced nebulizers, two examples are Perry, and again what you're seeing here is the nebulization is enhanced or is increased during the inspiratory phase. During exhalation there is still some nebulization, but compared to how much you would have normally. So basically we're able to conserve medication, and if we're doing it in an undiluted form, we definitely want that. Nebutech is another example that is there. Another example would be the circular, where you end up having a reservoir bag that the patient exhales into, and when they draw on a subsequent breath, they can draw some of that medication back in again. This is kind of the schematic for it. And again, what you're doing with this is, again, it's nebulizing continuously, but more, and it's enhanced during the inspiratory phase, and that reservoir bag captures it, and the aerosol, and the patient can breathe it back in again. Method 2 is to use a high-dose bronchodilator, where we were using subsequent treatment. We talked about this before, a back-to-back-to-back therapy. So we're doing our albuterol with our albuterol. Gotta take my spelling here. And we're giving one-to-one treatment every 20 minutes, followed by, and we're just basically repeating, and reassessing at the end. Method 3 is where we're going to use an MDI with a valve holding chamber, and we're going to do, instead of just our common 2 puffs, we're going to administer up to 12 puffs, and we're monitoring the patient to see how they end up doing. And method 4 is, I know Lori talked about, was a continuous bronchodilator therapy, where we're using a heart nebulizer, and we're going to go ahead and deliver a higher amount than we ordinarily would. Instead of administering 2.5 milligrams, here I'm administering up to 15 milligrams, which you guys can't see because those boxes are in the way. I just realized that. Oh well. It's okay. And what we're going to be doing, because it's a continuous therapy, we're actually using an IV pump and basically continuously dripping that into our heart nebulizer, so that we got a prolonged therapy there. So those are our 4 different ways that we would end up doing a higher dose than we ordinarily would have for patients that are in need. Scavenger systems, just want to talk about the RespiGuard. This is something where we don't want the exhaled aerosol to get into the atmosphere or to get into the room. So there's certain drugs that would warrant use of a scavenger system. Pentamidine, used for patients who have pneumocystis carinii, pneumonia, ribavirin, antibiotics. Morphine, interestingly, kind of be good for the caregiver not to be inhaling morphine, at least on the job. But morphine can be nebulized, and actually is used in patients that are having dyspnea that can't be relieved any other method, end-stage cancer patients or end-stage emphysema. And there's always a thought of nebulizing insulin. There actually was a product on the market that kind of didn't have good response, so they pulled it, but I wouldn't be surprised if one day it's, something like that comes back. This is an example of a scavenger system where I'm having my nebulizer, standard nebulizer, my mouthpiece, but when they exhale, there's a one-way valve here so that they can only exhale through the filter, and in the process then the aerosol is filtered out, so you don't have it getting into the atmosphere. And just another diagram of it. You can see the one-way valves there. Ultrasonic, we talked about before, using for bland aerosol therapy. Again, it's that piezoelectric crystal that's vibrating at a high frequency to create the aerosol. You get a really good high output. We know that particle size is inversely proportional to the frequency, and the frequency is fixed, but what does change is the amplitude, and that changes the amount of output that you end up having. An example of a medication being administered with that piezoelectric. We typically use these for sputum induction. We don't typically use ultrasonic nebulizers for medication delivery. You can, however, the ones that are the units that are used for this purpose, there is no couplant chamber like there is in our traditional USN. Instead, the medication is placed directly and comes in contact with that transducer that's vibrating. The one that we see a whole lot more, especially on mechanically ventilated patients, is what is called a vibrating mesh nebulizer. And it basically is made up of an element that vibrates and causes this thing called an aperture plate, which has very, very small holes to allow the medication to be passed through there. Pretty much can be used with most drugs, but some stuff that's really viscous might not be as effective. It may block it off. Just a couple different, you can either have an active vibrating mesh or a passive vibrating mesh. The active ends up here's you can see the aperture plate that is there in the center, and then when we magnify it, there's a very, very small holes, and it makes a very, very fine mist. It's a very effective nebulizer. The passive one uses what is called an ultrasonic horn to push the fluid through the mesh. There's specific drugs that are typically used that use this passive mesh system. This is another picture. You can see the mesh, the vibrating horn pushing that medication through, creating the aerosol. I can't read that, so I'm not going to expect you to as far as that. But that's an example of a passive mesh. One of the uses for it is a drug called Ventavis or Iloprost, which is used for pulmonary hypertension. Pretty interesting drug. Most times you won't encounter that drug unless you work in an environment where they have a big pulmonary hypertension clinic. So we don't see that. I don't know if you've ever administered it or not, but it's kind of specialty. A couple of other examples of them. I don't expect you to know it's got 6,000 holes. But basically there's a couple of other ones that are there. So some of the advantages and disadvantages. You can go ahead and take a look at comparing the SVN, which has some very good advantages. Don't need to have patient coordination. Unfortunately, not all meds are available in that fashion. USN and vibrating mesh, again, coordination is not required. There's nice part is that there's no volume being placed in, which is why it's nice with a mechanically ventilated patient. Some of the disadvantages, they're a little bit more expensive. The medication cup needs to be cleaned. And again, not all medications can be used in that fashion. MDI is convenient, portable. For the most not really expensive. But there is a high degree of patient coordination required, and we know some of the problems associated with them. And then the MDI spacer, again, gets not as much problem with patient coordination or pharyngeal deposition. But again, it's an additional cost that is there. And DPI we know it's breath activated, small and portable, and then the disadvantages is not all meds are available, so you can go and see that one. This is just a chart comparing the various depositions that you end up having. So what we're looking for is a large amount of blue, and you can see each device has has differences, with the MDI with a valve holding chamber having the best. And I won't even get into the electrostatic. SPAG I'll just mention. There it is. We don't use it. We used to be used for the drug Virazol, which was used to treat bronchiolitis. It's no longer a recommendation. It gives a very nice particle size, so we're getting pretty much alveolar deposition. Just want to make some mention of hazards. When you nebulize, one of the things that can end up happening is those heavier particles fall back into the nebulizer, and that may alter the concentration, and you can end up getting, especially if we're looking at long-term nebulization, you can end up having a shift in the drug concentration as the nebulization happens. It's also because it's particles that are aerosolized, you can end up carrying pathogens. Want to make very sure that we're using good hand washing technique. If the equipment needs to be changed, it's changed frequently, and we're using sterile solutions when we're delivering the medication. And if we're done, we're going to rinse it not with tap water but with sterile water. Another hazard is you becoming exposed, especially things like TB. And we talked about some of the harmful medications where we want to use an isolated system, a scavenger system. So always want to keep that in mind, that we're potentially exposed to the medication. Again, filtered scavenger systems, isolation rooms that have a lot of air exchanges, and there's also individual stations or booths that we can use for sputum induction. And there's an example of a mask that can be used for nebulizing, and as they exhale out through these filters, so it's not contaminating the atmosphere. Obviously a little more expensive. This is another medication that has an exhaled filter here on top. N95 masks, or what we would use. And lastly, just want to talk about protocols. Again, this is an example of the high dosing options that you end up having. Don't expect you to memorize, but just recognize there's different ways that we can administer a higher dose. Typically this is done in the ED, and this is talking about selecting for aerosols. What kind of options would you have? So let's take a look at some of these examples. 60-year-old man obtunded who requires treatment with a 0.5 milliliter of albuterol and 3 milliliters of normal saline. What kind of device would you want to use for that? As far as our options. MDI? DPI? SVN? How about an SVN with an aerosol mask? Not the most effective, but it's probably the best that we can end up doing because he's obtunded. And if and we'll talk about IPVB when we get to that, but if there's something where he can't take a deep breath, we can fix that. How about an AIDS patient who requires pentamidine? You want to use some sort of a scavenger system like the ResPreGuard, so that their exhaled aerosol is not allowing us to be contaminated. Alert 35-year-old woman in the outpatient recovery room after abdominal surgery needing albuterol. How about a large volume nebulizer? Okay. And a 55-year-old man with a trach. We can use that, again, in any kind of nebulizer, but attached to that trach mask. 30-year-old patient with pneumonia sputum specimen, probably going to use the ultrasonic with hypertonic. RSV, we're not going to do aerosol therapy. You'll still see orders for albuterol, but it's further down. It's not going to end up being relieved from that. You just got to kind of wait it out. 18-year-old asthmatic who's sensitive to propellant and the CFC, where they're getting the CFC MDI, I'm not entirely sure, because I think they've pretty much all been eliminated. But we certainly can use an SVN or perhaps even a DPI if they're able to take a deep breath in. Status asthmaticus patient admitted, not responding to treatments every 1 or 2 hours, and they want to use a higher dose. Again, we have all of those. Probably the most common one you'll encounter is just using a heart nebulizer and doing continuous nebulization. And I'll stop there.